Malika, so we welcome Dr. Lalit Verma, our President. He'll be talking on tips to manage when my vitrectomy infusion cannula is not in position.
Thanks, Ajay, for this wonderful concept of tips where in 2-3 minutes, you share your.
Manoj, can you?
So, you see, we are all taught that cannula has to be first in and last out. But there are situations like bullous detachment, like where choroidal thickness is expected to be more, like CD-associated uveitis, hypotony, end of small pupils. So there are situations where this position can bother you. So I'll show a small clip here. This patient, we have inserted this trocar cannula, and you see, by once we are depressing, we could not see the tip, and that is what is important to see before you turn on the infusion. So we did made the second port, and once the second port was made, so what was done was a small tip here was to cut this tissue in front of the previous infusion cannula, so that only once the tip is visible you can do that. So one tip is that you take preferably from the opposite quadrant, cut that tissue. So this was an eye. Second patient was an eye with actually endophthalmitis, where hypotony and choroidal thickness are there generally. So what I am doing here is a needle infusion to build up. You can use an AC maintainer also. So I first put in a needle and connect it to the infusion fluid, and then insert this trocar cannula straight in, not two plane incision. This was the story of another patient, 49-year-old male, who had small pupil, uveitis, posterior synechia, irregular pupil, plus a detachment. Detachment was predominantly nasal, and this is the color picture before. And you see, we started doing surgery. The only thing which was done wrongly was it was a two-step incision. So, although the infusion cannula was still visible, as you just saw, that I indent that place. So, but I continued, and suddenly the illumination has decreased here. So, this is another red flag sign if you are operating and the illumination suddenly decreases. So, this was the, to start with, and you see illumination has gone down, but still I could see I didn't want frequent exchange of instruments. So you can see this evidence of uveitis here, and there's a large break in the inferior part, and whatever vitrectomy I could manage, I still carried on with whatever visibility was there. And then I took out and put some infusion, this PFCL, to stabilize the posterior pole. And after that, came the chandelier. Suddenly the infusion got better. So at that time, the upper nasal port was the culprit where, the light was there. I was holding the light. You see multiple breaks. This was a third surgery this patient was undergoing. So we peeled all the membranes, paid attention to the PVR component of the surgery, and with better illumination, now that the illuminating port was clearly in the vitreous cavity. And retina started becoming balloonous at this stage. And once I was contemplating that I will start doing air fluid exchange after, being sure that whatever membrane surgery I had to do, I had done. So air fluid was started, and suddenly this air became subretinal now. You see the upper temporal part here. The air became subretinal. Now the fifth port came because I removed this, the tubing which was bringing in air. So this was the fifth port I made here. And this time I was very careful that I have to go straight in rather than a two-step incision. And again check whether you are inside or not. Again you see illumination has become much better. So at 2 points I was bothered by the subretinal location of the once illuminator, and second was the infusion. Now the air comes in nicely, retina got settled, and everything was good. There's nothing great in the surgery except that the cannula was was bothering me at least twice. So this was the post-operative picture. So take-home message is that there are some red flag signs, especially in situations which I told, when there is a hypotony where the thickness of choroid is more, or retina is balloonous. Suddenly it may happen per-operatively also, and the tips of the port illumination suddenly goes down, and air sometimes may go subretinally. So in such situations, maintain calm, and frequent exchange of instruments should be avoided, because this can create a dialysis there or a big tear. Sudden movements can create complications. So can change the position of the ports in relation to the bullous retina. And secondly is that port entry should be one step straight in, and preferably a 6 mm cannula may be of use rather than a two-step entry. Especially in these 4 situations which I have listed, here you have to be very, very cautious that this may become septal. Thank you very much, Ajay, for
Thank you,
this.
sir. I think you have beautifully captured the red flag signs and the solutions to the red flag signs by identifying, using a needle, using a cutter to remove the tissue, having a 6 mm infusion cannula, having an alternate cannula, and maybe have you ever used a sutured cannula these days with
Suture, it's a good idea. I haven't used it for a long time, but long time back we used to use a sutured cannula, and that was the role. When we had 20 gauge system, we always used to use a sutured cannula, and that you are right. That suddenly, once you are in the dark, suddenly the movement may occur and it may become subretinal. So fortunately, there was a close-by retinotomy, and from that I could. You see, I had a iatrogenic tear at that time, where was small bleeding there. So I put in this backflash needle there and took it out. And it was very early identification. And in case it was too much of an error, then I would have to manage differently. Here it was just beginning of the air pump. As soon as it started, I noticed that there is a mound of this thing coming up, and immediately change the infusion port.
and sometimes once you have a little bit air coming and you have an alternate infusion going inside, then maybe this, and you remove it, the air comes off. And even if I have done it once, that some air was left behind and I had to put in silicone oil, then the air got absorbed eventually.
So a lot of
Yeah.
yeah, yes, if you have an anterior break, because PFCL will work from the posterior pole upwards. So if you have a break anterior, it will come out. So a lot of these situations, it's preferable to have either a needle infusion or an AC maintainer. AC maintainer, you see, especially the eye pseudophakic. Even phakic also, it manages the fluid through the zonular apparatus. It can go there.
Thanks, Doctor. Any more questions from Dr. Lalit? Thanks, Dr.